Welcome back, everybody. It's been 3 weeks, and since our last episode of Ad Hoc with the Doc, here we are, our Facebook Live talk show. My name is Dr. Dan Rubin, Naturopathic Oncologist. I'm here with my longtime colleague, Dr. Melissa Coates. We've worked together for, what, a decade? Almost a decade. Yeah, coming on a decade. Both naturopathic physicians, and welcome to our show. Remember, Ad Hoc with the Doc is about what information you would like to know about a particular subject. We treated this episode a little bit differently. If you were watching our Facebook page, we gave 4 options for our followers and viewers and audience to vote on. And they were GI disturbance, adrenal fatigue, thyroid disorders, and low-dose naltrexone. I believe that were the 4. Yes. And based on how the votes were tallied and mixed up, it turned out that you thought it would be best to talk about low-dose naltrexone because it sort of spans the breadth of all of that.
It does.
I mean, from what I know, low-dose naltrexone has been used in GI distress disease. There was a sentinel study on Crohn's disease.
Yes.
That was years back. Fantastic study. I don't personally know much about its use in thyroid disorders, but I know some thyroid is autoimmune related.
Yes. It's really good for Hashimoto's. It's helped people get their antibodies down and kind of helps their thyroid become more efficient again when it has become sluggish and the antibodies are kind of taking over and just kind of making medication not work as well.
What does it mean? Let's start there. We'll start with thyroid, okay? So you started talking about antibodies to thyroid. Some people, that could sound overwhelming. What does it mean to have an antibody to like your own thyroid gland?
So it's basically it's an autoimmune condition. So you're attacking your own tissue. So your thyroid gland, which is located here in your throat, your body is suddenly starting to attack its own gland, and so that's where you will see antibodies raise up on your labs, and that's when your doctor can determine whether it's Hashimoto's or Graves' or some other disease going on. But most commonly Hashimoto's is found, and we've seen that beyond medication of the thyroid hormone itself, when you introduce low-dose naltrexone on top of that, you can get a more efficient use of the drug, and you won't need as much thyroid medication, and also the antibodies will start to calm down, which is really nice for people because the antibodies with Hashimoto's will go up and down cyclically and related to stress and diet and other things. And when you can get those down, they don't have so many peaks and valleys of fatigue and things like that.
Meaning it's creating more efficiency out of that thyroid medication.
Yes, and making the gland, in a sense, work better again.
It's a great naturopathic concept. Let's screech and halt for a second. We're going to back up a little bit. For those of you who don't know what low-dose naltrexone is, or even naltrexone, I think it would be a good idea for us to introduce to the audience what it is and how it works. And then from there, we can go on and take your questions. A reminder for all of you that are out there watching live, ask your questions because you'll get in the order that they come in, we will answer them. We had, again, a few people write in who weren't going to be able to make the live show, so we've got a few questions here. But if you have something you want to ask, or a friend wants you to ask, or you're curious about, write in on the Facebook page. We will get it and we will answer it in the order that they're received. If you're viewing this at a later date, hopefully we've covered. If not, give our clinic a call. So, Dr. Coates, what is naltrexone, and what is the difference between naltrexone and low-dose naltrexone?
Naltrexone is the dose typically given is 50 milligrams, and this is for people who are typically addicted to opioids, and what they're trying to do is get them to stop taking them. So they take this medication which sits on the opioid receptor, and then they will reject the medication, and so they will no longer do well by taking opioids, which will help them wean off of them.
So that's a big deal because there is an opioid crisis right now. So you're talking about something that can actually help people who don't necessarily want to be addicted to the opioids off their opioids.
Yes.
It's a big deal.
And that should be done definitely with a doctor's supervision and not something that you should try on your own and things like that. But that's why when we prescribe low-dose naltrexone, which is typically anywhere from 1.5 to 4.5 milligrams, you have to make sure that you're not on a narcotic or an opioid because it is contraindicated, because then you will no longer be getting the benefit of that drug if you're on it because you had surgery or something like that. So that's the difference. What they've also found is at low dose, it stimulates your natural killer cell function, which is why you've used it in oncology for years, and myself also. And so it does a lot of wonderful things. And then from an autoimmune perspective, like we said with Hashimoto's, it just basically, in many diseases, whether it's from the GI or the thyroid or elsewhere, it seems to calm things down. And they don't actually really understand that mechanism of action yet, which is interesting, but it's really not safe or anything like that. They've seen really good success with it.
So
at low dose.
Regular dose naltrexone could be used for helping people who say would be addicted to an opioid prescription drug and maybe getting it on the street.
Correct.
So naltrexone is only available by prescription.
Correct.
So they have to get it through a physician. Or somebody who may be doing illegal street drugs like heroin. Because I know if somebody comes in with an OD on heroin or alcohol into the emergency department, they're probably going to use one of these antagonistic drugs to pull them out of it.
And it has a lot of drug names that I don't know off the top of my head.
But in low dose forms, you're talking about it having value as an immune stimulator, which has value in oncology, which we certainly practice oncology together, and also autoimmune. So autoimmune disease, you were saying, is where the body is attacking itself. It just happens to pick the thyroid, for instance, as a tissue. Is that a common place to see autoimmune disease in people?
Yes, definitely.
And you see quite a few people with autoimmune thyroiditis?
Yes. And then another really common place is the GI, which we get to go into that area.
Let's talk about it. I'd say, do we have, from our production crew, are there any questions coming in right now? Okay. Let's talk about GI, and then I'm going to take the first write-in question after this.
One of my biggest early successes with low-dose naltrexone was with a patient who had celiac. And as you know, that's someone who cannot eat gluten. You know, they're very intolerant to gluten, and it basically gives them horrible GI distress if they even have their food pass over where gluten was at one point. And this patient was miserable, and when they were started on a low-dose naltrexone, all of the symptoms suddenly calmed down, and we were able to use other naturopathic things to heal up the gut and obviously get them off gluten. But the LDN seemed to be a real lifesaver as far as part of that treatment plan, and so that's why I got very interested in using it for the GI. I've used it a lot with Crohn's and colitis also, which is a big area that there's been some studies on it, and it's really nice to help people get off steroids with autoimmune conditions like autoimmune hepatitis or hep C and things like that. So it's been a really useful tool.
How do you think helping people get off their steroids is related to its immune effects, or do you think there might be something else happening?
I think there's something else happening that they don't quite understand yet.
Which is a very interesting point, because naltrexone in itself, like Dr. Coates said before, is what's called an opioid antagonist. That's a complex pathway. What is it? What is a natural opioid? Talk a little bit, if you can, for our audience and for me too. What does it mean to block opioids? What are the opioids that we have in our bodies? Like, we make them.
Yes.
The endorphins that we have.
So endorphins are things that help with pain. You know, so we have, I guess this is, I don't know, substance P is considered one, but that's.
So if we fall down and bruise our bone,
yes,
we produce endorphins.
Correct.
Okay, I got it.
Things that will kind of block pain from going out of control. Your body has a protective response, so that's the opioid. And natural things that even some of the things in your diet can actually stimulate those receptors. And other things can sit on the opioid receptor too, which is why there's a reason to consult before you do that.
So we like endorphins. Endorphins are what make us feel good. I'm a long distance runner. It takes me quite a while and quite a few miles to get that sort of runner's high that people talk about, but I know there's nothing like it. I know you've been a competitive athlete before. You've probably felt the same thing. We like endorphins. We like enkephalins. So we have a question here, and I'm sort of phrasing it. This is from John from the state of Washington. Asks about maybe what some of the side effects or contraindications are. But if we like having endorphins in our body, why is it good to block it? And is it a temporary blockade? And if so, what are some of the side effects?
Well, the contraindication of using it, like I said before, is if you're on an opioid, because obviously you don't want something to sit in place of your medication that you're using for pain. Pain sometimes too, if you have certain individuals will sometimes have a greater pain response when they take LDN. So that's why you need to start slow and make sure that it works out. And that's probably because it's replacing one of the receptors of pain. But otherwise, from a contraindication perspective, there's not really, or side effects, I haven't really seen a ton of them at all. Once in a while, people will say they have vivid dreams, which is probably some of that talking to your brain chemistry. But it usually goes away after a few nights of using the drug, or they just switch to using it in the morning instead of at night when it's typically dosed.
Do people enjoy the vividness of the dreams? Do you ever hear that?
Most of the people like it. I've had a couple of patients tell me it was vivid, but then they got better and it wasn't a problem. They're not like nightmares or anything like that. But if you're prone to that, it might be something to think about.
Okay. Do we have any questions coming in right now from the audience? Not right now. Okay. So Sarah from, well, actually she didn't tell us where she's from, asked, is it safe for kids?
I can attest to this. Yes, I did some research because I have a number of young adults that are on it for various reasons. And there's actually studies that it doesn't do anything to harm puberty or anything like that. It's actually been used for fertility, so it's not blocking any of the hormones that are going on as someone grows. So yeah, there's no problem with using it with kids. Obviously, you just need to make sure that you're dosing appropriately.
Okay. From an oncology perspective, Sharon from Rhode Island. Why is Rhode Island important to naturopathic medicine?
Just got licensed.
Woo! Rhode Island is this the 18th state or is this 19th?
I think so. I don't know. I have to add them all up.
You know, it's okay that we can't keep track because that means more and more states are being licensed. So Rhode Island, folks, is now a newly licensed state for naturopathic medicine. If you don't know out there in the audience, naturopathic doctors are not licensed in all 50 states. So it's very important to us that we gain licensure. They have a good licensure. Thank you for writing in and asking. Question is, can you use it while on chemotherapy or radiation? Now that's a good question. I like that one.
The answer is yes, and you can probably elaborate on that too.
But
yes, definitely you can. We use it a lot in oncology to help bring up your natural killer cells, which is important for fighting cancer. It's part of your immune system to help you fight and scavenge the land for things that are not appropriate in your body. But yeah, there's no problem with that. Again, it's really just if you're on pain medications that are narcotic based that you shouldn't do it.
Indeed, right. So I'm gonna explain one thing that
Sure.
you went through, and you've said a ton of stuff. We make opioids in our body. They're called endorphins and enkephalins. What Dr. Coates was saying is, if you're on an opioid medication like oxycodone or morphine or hydrocodone, generically, of course, then the use of naltrexone would be contraindicated because it would render those medications ineffective. And I just wanted to clear that up.
Yeah. But NSAIDs like a ibuprofen or a Tylenol are fine.
Okay.
It's not the same receptor, so it's okay.
It's not the same receptor. It's a big important point. It's a different mechanism. So I did have a patient who we had been giving low-dose naltrexone to while on radiation, and we hadn't talked to her for a little bit. She began to have painful sight of where the radiation was, and that's because radiation burns by design. It is a burn. It's like a giant sunburn every day that your body fights against. But in treatment, if it's necessary, it's necessary. It's part of the continuum of, sometimes you need to harm the body to get the desired result. But if somebody's going through treatment that may cause some kind of pain, then naltrexone use may block your own natural pain control mechanisms.
Correct. So that's just why I said earlier, if you are under pain, you might want to not go on it. You just have to it depends on the person though, it may or may not happen.
I understand. So some of the historical uses, well actually I know there's controversy regarding who was the first practitioner to use naltrexone from its non-hospital or non-emergency department uses. The one that I follow is Dr. Bernard Bahari, who passed away about 7 years ago, but who had been using it to try and stimulate the immune systems of people with AIDS, HIV and AIDS. And I believe this started back in 1994. That's what I know. If there's controversy's fine. I don't know all the stats. I just know what we use today. I personally have been using it for almost probably 18 or 19 years in clinical practice. I know since you've been practicing, you've been prescribing.
Pretty much been using it.
And there are now annual symposiums dedicated to low-dose naltrexone. Talk to me about, because I don't know much about it, but I did read about it being used to treat, for weight loss or for obesity. I think it was complex with bupropion, which is another medication.
Yeah, they've been mixing it lately with a lot of different medications to help, and some people say that it makes their appetite decrease a little bit, so that is helpful to them losing weight loss. I know I've seen on some chat boards where people have actually lost weight since starting LDN, whether that was necessarily their goal, it just ended up happening, so I think that's why the drug companies have caught on and added it in. So, yeah, I'm not exactly sure why it's helping with weight loss, but if it is appetite, that's one thing, but I don't know if there's another mechanism going on, but it could be that it's making things like their thyroid or things that were in the background that maybe were sluggishly work a little bit better, which is part of that unknown amazing mechanism that we don't know
everything. There are many drugs out on the market which I as a healthcare practitioner look up mechanisms of action, and it can say in the FDA approval, the mechanism of action of this drug is not actually known. So it's okay that we don't necessarily know exactly how it's working. Observational medicine can be okay. Then it's taken to study. It's proved to be effective. Sometimes medications just aren't known. It's the great unknown sometimes. Okay, to be fair to our audience, we've talked about low-dose naltrexone. That's quadrant 1 of the voting. We've talked a little bit about GI distress, and you've talked about how it can help in, say, some autoimmune or some inflammatory bowel disease problems. We've talked about autoimmune thyroiditis or Hashimoto's thyroiditis. We haven't talked about adrenal fatigue, what that means, if it's related. I don't know how robust the votes were in there. Do you know?
It's fairly balanced.
So we owe some audience. Okay. If it's related, or maybe LDN really isn't related, and we can just talk and give a couple minutes because we're coming to the end of our show time here. But let's talk about adrenal fatigue, and maybe it's another subject for another ad hoc. We'll see.
From an adrenal perspective, connecting LDN to that, I would probably say that, again, it kind of goes to that unknown mechanism of action, but a lot of the chronic diseases and autoimmune things like lupus and hepatitis C and things that actually cause fatigue, just the longer that you have them, it seems to kind of help with their adrenals and kind of give them energy when they've gone on the LDN. So I don't understand exactly why that works, but that is probably one of the things, probably an efficiency aspect of helping that organ work better, perhaps, with the adrenals. But adrenal fatigue or chronic fatigue is definitely something that a lot of people have.
What is adrenal fatigue? What it's a broad sort of spectrum of things. What actually is it?
Your adrenaline or your norepinephrine and epinephrine that are secreted by your adrenal glands, because we all live under stress or are constantly on caffeine or other stimulants, they kind of have been on for so long.
I like caffeine. I'll take some
Which I'm not saying that it's bad. It's just that oftentimes we are living cup to cup and we're not getting enough sleep or not taking care of our bodies. Eventually your adrenals just can't keep up with what you're doing.
Because today's world is stressful.
It is. It's just a stressful
world. And this is a big deal.
And so that's just eventually we're all kind of burning out. And because we're never turned off, we're always constantly, on Facebook, which is fine, or, or connected to our social media or internet, or, you can't get away from people anymore. There's always a device or a way to get a hold of us. We don't ever really turn off. And so, they've shown that even in toddlers, they react to your phone, and if they hear it ring, they're like, oh, get your phone. It's amazing. I know my toddler does that. So it's an adrenal thing, we're just burning ourselves out.
Can you live without adrenal glands?
I don't think that would be a good idea.
You would have to take hormone replacement.
Yeah, you'd have to be on a hormone to do that, because it controls a lot of important things too, like your heart rate and your breathing and other things like that. So this is why your adrenals are important to you, and you don't want to let them completely burn out. Your cortisol, is related to that.
So what we've talked about today, low-dose naltrexone, and now this sort of quadrant subject matter of adrenal fatigue, this isn't stuff that if you're just seeing a traditional allopathic physician, you're not going to hear about this stuff. Or I'd be very surprised if you would. And if you do, then they're probably not a strict traditional physician. So these are concepts born out of naturopathic medicine. We are naturopathic physicians. There's nothing quite like what we do. If you're interested, you can always look at our website. You can give us a call. New patients are always welcome to call in and chat with the doctor or chat with the staff to see if this type of stuff is right for them, or if they have adrenal fatigue.
Yeah.
I can tell you that the amount of stress that people are under and the amount of chronic disease that we see, and the road to recovery for some of these people is long. But through LDN recovery is possible, nutritional consult, changing lifestyle, just like Dr. Coates said, even getting 1 more hour of sleep, or taking 50 milligrams less of caffeine, or getting out in nature, turning off your phone, staying off of social media for an hour per week. Anything can, reduce some of these.
It's a very complex. Adrenal fatigue isn't something I could talk about indefinitely in 5 minutes. It's
and maybe that's
complex.
Another subject.
Yeah.
So,
there's connection with so many.
So we're coming up on about 19 minutes. Could I take another question?
Sure.
Okay. Okay. So we've got, this is a great question. This comes in from Michigan. This is a fella named Stan. Since it's got so many benefits, should everybody take it? This person obviously read up on LDN or may even be on it themselves. But since it's got so many benefits, I think they're saying is this like a vitamin? Is this like an anti-aging? Is this like something that's going to heal me? And am I hearing, could this replace lifestyle changes or dietary changes? I think we should talk about that, because just popping a pill doesn't necessarily...
I think that's a great question, but I would say my answer is no. I don't think it's something that you can take this and it'll just fix everything. There's definitely a time and a place for it, but I think that there's a lot of things that we can do as a naturopathic physician before just putting you on LDN and hoping for the best. There's a lot of other things and changes that you should make in your lifestyle, in your diet, and sleep hygiene, and a million other things that you should do before we go there. But that's where, when we consult, we'll figure out when there's a time and a place for it, if it is in fact something that you need to be on.
So for the audience out there, if they have naturopathic physicians or allopathic physicians that are less traditional, and they want to inquire about the use of LDN, are there potentially guidelines we would give them, or there's sites out there? Is it worth them maybe discussing it with them?
I think it's definitely something to talk about with your physician, and if they're not versed in it, then see another person or to find someone who is. There are websites definitely out there already that have information on them, and I know there's chat groups too of people who are using it for various reasons, so that can get you a lot of information.
Yeah. Or we've had patients who have gotten information, say, off the internet or from wherever, and brought it to their physician, and we've seen some physicians start to utilize it. Yes. There are some issues. If you are bringing information to your physician and they are agreeing to prescribe it for you, it must be done through a compounding pharmacy. But it's very important that that compounding pharmacy be skilled on how to compound. You do not want to take low-dose naltrexone using a filler that has slow release mechanism. It doesn't work as well. You want a fast-acting, short release mechanism like Avicel or sucrose or lactose, but some people are lactose intolerant. So I would say this is great. Are there 4 take-home points about LDN that we can give to our audience? Like where to use it, if they have a certain diagnosis and or they might not be doing as well as they could? Where could they, who are the people that could bring this up to their docs?
Many different autoimmune conditions. Anywhere, also other diseases like Parkinson's, Alzheimer's, MS. There's a lot of ways that this can come in. Lupus, for example.
So
there's so many things.
Autoimmune. You said Parkinson's, or MS is autoimmune. Parkinson's. That's really interesting, because there is a big push on helping to understand the mechanisms behind Parkinson's.
They're thinking that it might help stop progression to be so quick with the use of LDN. At least that's what people have been bringing to me and talking to me about it. So I have a few patients for trying that to see if it slows down progression.
And you do quite a bit of work with people with Parkinson's disease and the aging population.
Yeah.
Very interesting. Very interesting for people who have relatives with Parkinson's or have Parkinson's themselves.
And I know that it's helped with MS with exacerbations when they have a flare.
Okay.
So
very important too. There's not a whole lot for managing MS. We see lifestyle changes, the use of LDN, use of other nutritional therapies help people with MS. So we've got autoimmune, maybe Parkinsonism or Alzheimer's. You talked about GI distress.
GI stuff.
You talked about people with cancer.
Yeah. And
4 good reasons to ask your doctor about low-dose naltrexone.
Yeah.
Thank you for watching Ad Hoc with the Doc, simply because there's nothing quite like being a physician. See you next time.